Good afternoon, and welcome to today's webinar on clinical searches. Thank you very much, everyone, for taking the time to join us today. My name is David Gwyther, and I'm a Communications and Engagement Manager here at CQC. I will introduce the rest of the team shortly, but first, just some very brief housekeeping. We hope that you find this time useful and productive. And please do bear with us if there are any technical glitches. The team is on hand to try and help out. We will do our best to stick to time, and we have 1 hour allocated for today's webinar. The way the webinar is set up, only the webinar team members will be able to speak, but you can use the chat function at the side of the screen to ask any questions. And we will do a presentation and then we will leave some time for questions at the end. If you experience any sound issues, please check that your screen is not on mute or your speakers are not on mute. Or if they continue, please try exiting and rejoining the webinar. This usually solves any sound issues that people might be having. The webinar will be recorded and it will be shared on our YouTube afterwards. And we will also send out the recording and the slides to those that have joined today and also those that signed up but have not been able to attend. So I would quickly introduce today's team. The presentation today will be given by Dr. Janet Hall, National Professional Advisor for General Practice here at CQC. To help answer questions, we have Dr. Tim Ballard, who is also a National Professional Advisor for General Practice at CQC. We are joined by Dr. Robert Grayville-Haygate and Dr. Merlin Dunlop from Ardens, who are helping to deliver the searches and will also help to answer questions today. And my colleague, Lisa Lloyd, another Communications and Engagement Manager here at CQC, will be helping with the Q&A. As without further ado, I will hand over to my colleague, Dr. Janet Hall, who will lead us through the presentation.
Thanks very much, David, and welcome everybody. It's such a beautiful day here in Sheffield where I'm based. It seems a shame to be stuck in front of the camera, but hopefully this will be a really useful hour for you. What we're hoping to cover today is to give you a background to the searches and our involvement with Ardens, to explain a little bit about the purpose of the searches, to talk through the business rules that sit behind the searches, and then to go through and show you how to access the searches on each of the main clinical systems used in general practice at the moment. They are EMIS Web, System 1 and Vision. I'm then going to take the opportunity to give you an overview of the searches and explain the thinking behind why we've selected these searches. And then finally, at the end, there's a quick overview slide to show you the other areas that are likely to be covered if you have a CQC inspection. Hopefully then we'll have plenty of time for any questions going forwards. So the background to the searches. David, could you have the next slide, please? Thank you. So the searches were initially developed in response to the COVID pandemic when travel seemed to be difficult. The inspection programme was only really focusing on at-risk inspections, and getting into surgeries to inspect those at-risk surgeries became very difficult because of the lockdown rules. So we developed clinical searches that could be imported into the clinical systems and run both on-site and remotely to be able to find out what the clinical care was like and whether there are any safety issues in these practices. The searches are now used on every inspection going forward, and they're also used for some monitoring purposes. As I've mentioned, they're used both in on-site and off-site inspections, and until recently these searches were imported into the clinical system using files downloaded by the specialist advisor. There's a whole suite of clinical searches that are routinely used, and I'm going to go through those in a moment in more detail, but these are based on safe prescribing, monitoring of high-risk drugs and in particular disease-modifying anti-rheumatic drugs, searches to identify potential misdiagnoses, Searches to identify if providers and practices have systems in place to monitor MHRA alerts and make sure their prescribing is in line with these. And then some searches to look at long-term condition management with a particular focus on high-risk patients. We also look more generally to see whether care is being delivered in line with evidence-based practice. From the 25th of May, all of these searches are now freely available for practices to access at any point in time through the Ardens website. And we've also made the business rules publicly available to ensure that there's transparency about what the searches are looking at, or if practices want to have a look behind the searches to see what it makes them up, if there are any queries about patients that have been identified. So the purpose of the searches. These searches are to identify the potential clinical risk, predominantly in relation to the delivery and safety of effective care. Next slide, please, David. The searches have a degree of tolerance built into them, so you may notice when you look at the searches that the monitoring intervals don't always align with the national guidance. For example, for DMARD monitoring, the national guidance usually recommends at least 3 monthly monitoring of blood tests. However, our searches identify patients who haven't had monitoring within the last 6 months. This has been done deliberately to make sure that we're identifying those patients who are of potential highest risk, rather than somebody that's just a few days over the monitoring interval. We know that these searches allow a more consistent approach and also provide robust evidence for us to make decisions on when we're doing inspections. We also hope by making them available that they will promote quality improvement, so that you'll be able to look at patients who are identified by the searches and to make changes to improve safety and care of patients. As I've mentioned already, you can access them at any time, and any updates will be clearly available on the Ardens website. It's really important to stress that these searches should not be used, in fact, should never be used as a substitute for the practice's existing governance processes. These searches are, as I've mentioned, risk-based searches, and they don't align with the national guidance in many cases, and therefore by using these searches as your only governance system would potentially put patients at risk. Therefore, we would recommend that you have your own searches and systems in place that align with the national guidance, and only use these to identify outliers. They should also not be used for managing care on a daily basis for the same reason. Next slide, please, David. So we're really pleased that we've entered into a pilot with Ardens. This is a 12-month pilot that started in April, and we recognise the benefits that Ardens bring to this project. As many of you will be aware and will have had access to for some time, Ardens produce a whole range of searches and templates that support the delivery of clinical care. Up until we started the pilot with Ardens, the searches were built by either myself or Dr. Tim Ballard, and we're not experts in configuring or building searches. We've learnt an awful lot and we've refined the searches as we've gone along, but we recognised, as these are becoming a more important part of our inspection process, that we needed to have some experts to help us with this, and that's exactly what Ardens have done. We went through a process of recruitment, and Ardens was selected, and it's been really great working with both Rob and Merlin and the team in order to get the searches out to all of you in a really timely manner. And we're hoping over the next year that we'll be able to work closely together to improve things even more. As I've mentioned, this is a 12-month pilot and we're hoping to achieve a lot in that time. If you have any feedback, there are contact details at the end of the presentation where you can make suggestions. The searches, as we've said, are already available for all EMIS Web and System 1 practices, and we're really pleased that we've been working very closely with all of the clinical systems providers during this process. Cegedim Healthcare are hoping to make the searches for vision practices available by the end of June. We've already been in contact with them and they're just going through the final stages of testing. So the next slide, please. So the business rules. Now, These are nothing to do with finance or anything like that. These are how the searches are built. They're the rules that sit behind the searches. They describe exactly what codes are used in order to build the searches and what the criteria are for each of the searches. These business rules are available on the Ardens website via the link that's displayed. And if you're wanting to query any search or look at as to why a patient may have been identified, you can see those business rules and interrogate them a bit more closely. We are, as we have rolled these searches out, gradually refining them again and again as we find minor glitches or codes that may need to be included in addition or others that need to be removed. So they are a live document and are constantly being monitored and checked. Next slide, please, David. So I'm now going to go through how you download and run the searches in each of the different clinical systems. First of all, I'm going to go through how you do this in EMIS Web. I apologise that the pictures on the right-hand side are a little small, but we are going to share the slides in the presentation so that you will have that to look at your own leisure. And we also have a video that we're going to sorry, got tongue-tied there, that we're going to show shortly to show you how it works in real life. So to download the searches from the Ardens portal, you go to the Ardens Live portal with the web link that's shown. You select the practice where you're wanting to import the searches to, and you select CQC searches followed by the download link. You can then save this folder in of the searches onto your desktop. When you use this site for the first time, you will be asked to create a free account and to register so that Ardens know which practice you're working at and also can ensure that you have the latest version of the searches as time goes on. We ask you not to share the downloaded searches, not because they're secret, because anybody has access to them, but in order to ensure that each practice has the most up-to-date searches relevant to their system. Next slide, please. So when you've downloaded the searches, to install them, you go to the EMIS button at the top left-hand corner, the big EMIS button, and select Population Reporting. You then create a new folder called CQC or whatever you want to call it, and import the downloaded file into there using the import button. You'll then be able to see each of the different folders that sit below the CQC inspection searches top folder. And as you can see on this slide here, they are DMARDs, DNA CPR, high-risk drugs, long-term conditions, medication review, medicines usage, misdiagnosis, and safety alerts. Whenever you click on one of these subfolder titles on the left, it will show the list of searches included on the right. Next slide, please, David. If when you've run a report, you want to break down the results even more, there is a quick way of doing this. So if you highlight the search, you will see a button which has got a lightning streak on it. If you click onto that, that will make an auto report to break down the searches more easily for you. Next slide, please. In this next slide, we're going to run a short video that lasts a couple of minutes just to show you that process in real life. So hopefully the sound will work. Thanks, David.
The following training video is for EMIS sites only and will show you how to download the Ardens CQC searches from the Ardens portal, how to import the searches to the EMIS practice, and how to run them once imported. To download the searches using an internet browser, navigate to www.ardens.live/portal. If you are using the portal for the very first time, you will need to create an account. To do that, click on the sign up option, and this will take you less than a minute to complete your details. And once completed, log in using the options below. Once you are logged in, click on the select button next to your registered organisation, and here you'll find an area for the CQC searches. Click on the CQC searches link and select the download link. Click on the download button located at the bottom of the screen. If you do see the following message, click on Keep to continue with the download. And this will then automatically download the file to your downloads folder within File Explorer. To import the searches to the EMIS practice system, within EMIS, navigate to the Population Reporting module. You will first need to create a CQC folder. Select the practice name at the top of the list, click on Add, Folder, and then name the folder. Once the folder has been added, ensure it's selected and then click on the Import button on the EMIS ribbon. Click on the three dots next to the inquiry document field and then navigate to the saved search file. Click on Open. And once the searches are populated under the inquiry document column, click on OK. Once the searches have been imported, to run the searches, right-click on the required search folder and click on the option for Run. Click on Yes to run the searches.
Thanks very much, and particular thanks to Charmaine who produced that really clear video. Thanks very much. Next slide, please. I've just been given a message that apparently 1,143 EMIS practices have already downloaded the searches, so that's a fantastic response given that they've only been live for a couple of weeks. So hopefully many of you are benefiting from them already. So I'm now going to go through how you download and run the searches on System 1, which is done by a slightly different process. So this is done through the System 1 clinical system itself. In order to access the searches, you have to join an organisational group. To do this, you need system administrator rights. So when CQC come to inspect, the specialist advisor will need to, as well as being given lead clinician rights, be given system administrator rights to download them if you haven't done already. To do this, you go to Setup, Users and Policies, and select Organisational Groups. You need to untick the left-hand box which says Only show groups this organisation has joined, where the red box is on the right-hand side, and then go to Wiltshire and CQC inspection searches as shown in the green box. Right-click on Join the Group, and then you need to turn System 1 off and back on again in order for that to be installed. Please note that your organisation can only be a member of 25 groups. It's very unlikely that you will be a member of so many groups, but if you are, you will need to leave another group first in order to download the System 1 CQC Ardens searches. For further information about how to do this, we've put a link on the slides to a support article. Thank you. Next slide. So this then shows you what you do when you've reopened and reinstalled the programme. You go to Reporting, Clinical Reporting, and select the CQC Inspection Searches folder. Again, you'll see on the left-hand side each of the subfolders shown, and if you click on one of those, you will see the categories of searches on the right-hand side. In System 1, they're displayed slightly differently to in EMIS. So if you're wanting to see the denominator of any search, for example, the total number of people on methotrexate, rather than just those who are overdue monitoring, you can go to a subfolder which sits at the bottom of the list. Next slide, please. This is a short video, again, produced by one of the Ardens team, so thank you very much for that, to show how to import the Ardens searches and join the organisational group. Thanks, David.
To access the CQC inspection searches, you first need to join the group. So to do this, you need to go to Setup at the top of System 1, down to Users and Policy, and into the Organisation Group screen. In there, top left-hand corner, make sure you've got unticked the Only Show Groups this organisation has joined option. Once you've done that, you need to find the Wiltshire folder, and within there, there'll be a CQC Inspection Searches group. Right-click on that to then join the group. Once you've done that, you need to restart your System 1, so shut it down as normal and open it up again. Now when you go into your clinical reporting screen, so your reporting menu at the top and down to clinical reporting, you should have a folder then that says CQC inspection searches. If you open that folder up, you'll see you've got all the different domains for the various reporting groups, and within there are able to run those searches as needed.
That's great. And again, thank you for producing that video, which is really helpful and is available on the Ardens website if you want to watch it again without opening the PowerPoint. I've also been informed that 811 System 1 practices have already joined the organisational group. So that's over nearly 2,000 practices that are accessing these searches to improve patient care, which is great. Next slide, please. So I'm now going to go through how to download the vision searches. As I said, the vision searches should be available by the end of June, and I'm just going through the final stages of checking. So to download the searches, you click on the chevron at the bottom level of the bottom left of the screen in the system tray, which is shown by a green box on the top picture. You then select the download web files as shown in the red box, and then select CQC clinical searches. You download the searches if it's not showing as up to date by checking the download box as shown in the yellow box, and then select the download button as shown in the purple box. The vision searches are going to be available through the clinical system and aren't downloadable through the Ardens website. Next slide, please. In order to run the searches in Vision, again, you go to the chevron at the bottom of the screen and in the system tray, and you select practice reports in the red box. You then select practice lists and then select other and type in CQC into the search box. You then click on the clinical searches for CQC and choose run. If you click on any of the plus symbols next to the category headings, you will see the results and the patient lists affected. We're now going to show a video to show you how to do this. Thanks, David.
In this short demonstration video, we're going to look at how we can download the new CQC clinical searches and also how we run those searches from within the Vision Plus module. We start down in the lower right hand corner of the screen at what we call the system tray. That's where we can see the date and the time and two small chevrons. Those chevrons, if we click them, open a menu to show hidden icons, and within that menu we can see the white cross. That is the Vision Plus icon. If we right click that, we'll see the Vision Plus practice mode menu, and from within that menu we choose the option to download web files. Download web files shows a list of searches that are available to the practice. We can see we have search names, a status, a web version and a local version. If the web version is more up to date than the local version, that particular search will need to be updated. If we look down the list using the scroll bar, we'll ultimately get to the new CQC clinical searches, and we can see these are currently not downloaded. So I'm going to check the download box, and then from the main menu, I'm going to choose download. That starts the download process, and we'll see a progress indicator at the bottom of the screen. Once the download process is completed, we can see that the CQC clinical searches are up to date with matching web and local versions. And that concludes the download process. Once we have the CQC searches installed, it's now time to run those searches and see our results. To do this, we need to launch the Vision Plus module once more. So we move down to the lower right corner to the system tray, and we right click the Vision Plus icon again. This time from the menu, we're going to launch Practice Reports, which is the Vision Plus reporting module. And when Vision Plus is launched, we'll see we have a menu down the left hand side, And from that menu, to run our reports, we're going to choose Practice Lists. Practice Lists then reveals a submenu, and from that submenu, we're going to use Other. Now, there are quite a few searches on the list, and we need to narrow that list down. So to make life easier for us, we're simply going to put in our search box CQC and hit return, and that will take us to CQC clinical searches. I'm going to left click that now to launch the search, and it will ask us if we want to run now or schedule for later. I'm going to actually run these searches now. Now I'm using a test system with test patients. So it's just asking me in my example if I want to run just for 500. I'm going to go with that. Now once more as the searches generate, you'll see a progress bar at the bottom of the screen. Once the run is complete, we will then see a list of categories. Down the left-hand side, in each of those categories has a heading and also a count. That's for the number of patients within that category. So to see the patients within a category, I can click the plus symbol here, and I can see the patients within. And don't worry about this data. This is all test data on our training system. So these patients are all fictitious. So that's how we can download and how we can run those CQC searches to produce our figures.
So particular thanks there to Andrew Nichols, who put that little video together to show us how to do that in Vision. As you can see, we've had a lot of support, both from Ardens, but also from EMIS Web, EMIS Health, TPP System 1 and Sejadim Healthcare Solutions for Vision during both the initial conceptual discussions, during support as we developed the searches over the last year, and now as we're launching the searches for practices to have free access to. So a particular thanks to all of them for their support and help in allowing us to achieve this. Next slide, please. So what I'm going to do now is explain how the searches will be used by CQC if they come out to inspect your practice. The CQC SPA will download and run all the searches from all the domains, and will select searches from each category according to the perceived risk when they review the results. They'll choose at least one search from each of the domains listed, and then review at least 5 patient records from each search to check that what the risk is to those patients. So for example, if a patient is showing as having monitoring overdue, but when we then look in the clinical record, we can see that the results are on ICE or the hospital system, or the patient has been having the monitoring done at the hospital, or the patient has discontinued the drug, that will obviously reduce any perceived risk that was initially suggested. I'll go through the searches in a bit more detail in a moment. We are now aware that many of you will be working on these searches, and what we want to ensure is that practices have got safe systems and processes to ensure regular recall and call for these patients so that they achieve the monitoring at intervals that is required. So if all the searches in a particular domain show a 0 when we come, that's fantastic, but we will also be reviewing those 5 patient records for one of those searches to check that the results haven't just been done before the inspection, but have been done on a regular basis to ensure that robust monitoring recall processes are in place. So I'm going to go through each of these different categories now. So if you could put the next slide up, please, David. So we have refined the searches since we've joined with Ardens to do this pilot. All the categories remain the same, but we have removed some searches that were less useful, and we've refined and reviewed all of the criteria to make sure that they're fit for purpose. So for the DMARD medications, we look at the 3 most important DMARDs that are prescribed in primary care. These are azathioprine, leflunomide and methotrexate. We've reviewed the BNF and the NICE CKS guidance, and also the Specialist Pharmacy Service guidance and the British Rheumatological Society guidance to ensure that we know what the best evidence is for the monitoring, which usually recommends monitoring every 12 weeks. For azathioprine and methotrexate, this should include full blood count UNE and LFT. And whereas monitoring is recommended within 12 weeks, because we're looking for patients who may be at risk, we have extended this interval to look for people who haven't had any monitoring coded in their clinical record in the last 6 months. For the flunomide, we're also looking for the blood test monitoring for full blood count UNE and LFT, but actually many of the much of the national guidance also recommends that blood pressure and weight are checked at each monitoring review. For DNA CPR, we run these searches basically to identify cohorts of patients who've either had a DNA CPR or respect form completed in the last year. We look for those who are still alive, who are their active DNA CPR forms, and also to look at those who have unfortunately died in the last year to see how their DNA CPR was used towards the end of life. The GP specialist advisor will be providing 5 names to the inspector, who will review with a member of the practice those records according to a template to check that the DNA CPR was made in accordance with the guidance. For example, it wasn't done as a blanket DNA CPR, that the patient or carers were involved in discussions. Next slide, please. The next category is high-risk drug searches, and this looks at a variety of high-risk drugs where monitoring on a regular basis is required. You'll see down the left-hand side of the table the list of drugs that we look at and the searches that are undertaken on the right-hand side. So you will all be aware that ACE inhibitors and angiotensin receptor blockers require regular renal function monitoring because of the potential risk of them damaging the kidneys and also raising potassium levels. Monitoring is usually recommended every 12 months or possibly more frequently, depending on the other comorbidities and drugs that the patient takes. And again, we look for risks, so we're looking at people who haven't had monitoring done in the last 18 months. For amiodarone, we look for people who haven't had blood monitoring of UNEs, LFTs and thyroid function tests in the last 6 months, in line with national guidance because of the risks associated with this drug. And you'll see that there are quite a lot of searches associated with DOACs. These are particularly in relation to the creatinine clearance levels, and we have found when we've gone out on inspection that practices often aren't aware that they should be monitoring and calculating the creatinine clearance level rather than just relying on the eGFR and UNE. So when a patient on a DOAC has their UNE taken and their eGFR is calculated as part of that test, practitioners should then be using the software embedded within their clinical system to calculate the creatinine clearance level, which takes into account other factors such as their age and their weight. It's important to have an up-to-date weight to do this correctly. And obviously you will be aware that depending on what that creatinine clearance level is, depends on how frequently patients should be monitored with regards to their UNEs, and also what dosage of the drug they should be prescribed. And this is why we have got the different breakdowns of the searches to identify patients who have got different levels of creatinine clearance. As this medicine also can affect bleeding and make people anemic if they are bleeding without it being realised, we also look to check those who have had a low haemoglobin in the last year. With lithium, this is obviously a very toxic drug that requires very close monitoring, and lithium levels should be done with every 3 months. There are obviously strict criteria about when this should be done, at least 12 hours after the last dose. And there are many reasons why certain cohorts of patients should have even closer monitoring, especially when they're just starting the drug. Patients taking lithium should also have their renal function, thyroid and calcium levels checked. This should usually be done every 6 months, but we're looking for people who haven't had it done within 9 months. We also look at people taking aldosterone antagonists, potassium sparing diuretics. Again, because these should be monitored very closely due to their effect on potassium levels. And we look to check that people have had UNEs checked within the last 6 months because of the risks associated with these patients who often have underlying conditions such as heart failure. And then for patients taking warfarin, we look for those who haven't had monitoring done within the last 3 months, particularly if they aren't recorded as doing self-monitoring. And we look for those who have had very high INRs in the last 6 months, who it may be more appropriate to consider a DOAC for if their clinical condition allows. Next slide, please. We also have built a series of searches for looking at long-term conditions, particularly for patients who are at high risk in this area. We recognise that during the last few years in the COVID pandemic, the RCGP and BMA produced a work prioritisation document, and we've taken that into account in consideration of these searches. We consider that these searches identify patients who are at potentially high risk because of their long-term conditions, and therefore should have had regular monitoring throughout the pandemic. So for the asthma search, we look at people who've had at least 2 courses of prednisolone during the last 12 months who haven't got COPD. And we look to check that when they've had those exacerbations, appropriate histories and examinations have been taken, that they've been followed up according to the NICE guidance, and that they've had their asthma treatment stepped up and down as appropriate, and where necessary, had a steroid card issued. For patients with chronic kidney disease, stages 4 or 5, or the latest eGFR less than 30, we look to check that they've had renal function done in the last 9 months. It should be within 3 to 6 months, depending on other factors and which subcategory of CKD they've got. For diabetic patients, we look at those who've already got established retinopathy and have poor control of their diabetes with an HbA1c of over 74. We look to check that they've had their medication reviewed, that they are being seen regularly to adjust their medication to try and improve the control of their HbA1c, and also that they've had blood pressure monitoring done. For patients with hypothyroidism, we look to make sure that they have had their TSH done within the last 18 months. And as you'll be aware, this should be done annually. There's a sub-search done to identify those who had abnormal TSHs when they last had the blood test done, who potentially should have had another test done even more recently. We then look at misdiagnosis. So this is trying to identify people who may have an underlying long-term condition that hasn't been identified or hasn't been coded. We look for patients who potentially could have chronic kidney disease, stage 3 or to 5, by looking for people who've got 2 or more eGFRs less than 60 in the last 2 years, including the latest eGFR. We're aware that this search may pick up people who may not have chronic kidney disease, because it's not possible using the software to check for consecutive results that are the correct interval apart to make the diagnosis. But this is why it's important that our GP specialist advisors review the records behind these searches to check what the risks are. We also look to identify patients who could have diabetes who haven't been coded with this. For this search, we identify people who've got 2 or more HbA1cs greater or equal to 48, but we exclude certain people. So those with gestational diabetes, those with steroid-induced diabetes, or those with haemoglobinopathies. You may find some people on this search who have had a code of diabetes excluded, diabetes resolved or diabetes in remission coded. These people may be picked up if 2 subsequent HbA1cs have been recorded after that diagnosis was added, meaning that they have then developed diabetes again. We're aware again that this search has some failings in that we can't select consecutive HbA1cs, but if people have previously had HbA1cs in the diabetic range on 2 occasions that are consecutive, they should have been coded as being diabetic, even if results have improved subsequently. In that case, depending on what the HbA1c has come down to and whether they're taking medication, it might be appropriate to code them as diabetes in remission or change the code to pre-diabetes. Next slide, please. We then also search for patients who've had medication reviews done. Again, this just looks for a cohort of patients, either of any age or those over the age 75, who've had a medication review coded in the last 3 months. We look at a selection of 5 patients in line with these searches to see what quality of medication review has been undertaken. We look to check whether the patient's been involved in that review, whether monitoring is up to date, whether prescriptions are aligned on the repeat screen, and whether they've been updated to remove any medicines that haven't been issued for several months. We also look to make sure that it isn't just a code that's been added without any evidence of the patient being contacted or informed or monitoring not being up to date. We also look to check whether prescribing is in line with the MHRA alerts and other national guidance. We also do searches to look for medication usage. And for this, we look at asthma patients who've been prescribed 12 or more SABA inhalers, patients prescribed benzodiazepines and or Z drugs and have had 10 or more prescriptions in the last year, and those prescribed gabapentin or pregabalin who have had 3 or more prescriptions in the last 6 months, but no medication review done in the last year. Obviously, these medicines, particularly the benzodiazepines and Z drugs and gabapentin and pregabalin, should be monitored closely because of their addictive potential in relation to the benzodiazepines and Z drugs. With relation to the asthma search, we have found on many inspections that there has been a lack of control over the issue of SABA inhalers, particularly if they've been put on repeat. There have been large numbers of SABA inhalers issued without reviews having taken place and without treatment being stepped up or down as appropriate. So please do have a look at this search to make sure that patients aren't being prescribed excessive numbers of short-acting beta agonists, which may indicate that their asthma isn't being controlled properly and increases their risk of death. Next slide, please. We also look at searches in relation to MHRA alerts, and these searches are updated as new alerts come to the front, even if they are considered to be significant. So these searches look at some single drug alerts and some combination drug alerts, and they cover a range of years when the alerts have come out. So for hydrochlorothiazide, this is a cohort search. It looks for patients who are prescribed this medicine, and we check in the records to see whether patients have been warned of the increased risk of skin cancer and to report any abnormal skin changes. For patients prescribed citalopram 40 milligrams or escitalopram 20 milligrams who are over the age of 65, there's an increased risk of torsade de pointes, and so these people are at increased risk of potentially fatal cardiac arrhythmias with extension of the QT interval. So it's important that patients over the age of 65 have these medications reviewed and reduced if possible. We look at people who've been prescribed clopidogrel together with omeprazole or esomeprazole, where there is some evidence that the omeprazole or esomeprazole may inhibit the antiplatelet effect of the clopidogrel, which could potentially cause problems for patients. Another search for DOACs following an alert where patients with mechanical cardiac valves shouldn't be prescribed a DOAC, but should be maintained on warfarin. So if you've got patients showing up on that search, you need to just have a little look to check what sort of mechanical valve they've got. An alert for febuxostat showed that those with major cardiovascular disease are at increased risk of mortality if they are prescribed febuxostat. So again, it's important to review these patients, to warn them of the risk and to check whether there are any alternatives. The fentanyl patch search looks for those who've recently been prescribed fentanyl patches who haven't had any previous opiates in the last 3 months, following an alert that showed an issue with this because patients could react badly because of being opiate naive. Patients prescribed mirabegron should have an annual blood pressure test done because of the risk of hypertension with this medicine. And then, as per some of the previous high-risk drug searches, we've got searches that look at combinations of ACE inhibitors or ARBs together with potassium-sparing diuretics with the increased risk of renal impairment and hyperkalemia. to check that they've had monitoring done in the last 6 months. And we want to make sure that people aren't prescribed multiple renin-angiotensin system drugs in combination because of the risk that this can cause. The SGLT2 inhibitor search looks for patients who've been prescribed these medicines to check that they've been informed of the risk of Fournier's gangrene and to report any redness or ulceration in the groin area, and also given advice about the risk with diabetic ketoacidosis. Then we have a very old alert that we look for with patients prescribed calcium channel blockers who shouldn't be prescribed higher doses of simvastatin, to make sure that these patients are switched to more appropriate medicines. And then, as has been in the news recently, we look for the prescription of teratogenic drugs in childbearing age to make sure patients are aware of the risks, have been prescribed highly effective contraception, have pregnancy prevention plans in place, and are under specialist care where necessary. This has been combined into one search looking at all of those drugs. Next slide, please. So this is just a summary slide. Given that this talk is primarily on the searches, I thought it might be just useful to give you a little idea of some of the other areas that we look at on inspection when we come to do an inspection in the surgery. I won't go through all of these areas now, but it's there for you to look at and to reflect on to make sure that you have got all of these things in place and are ready to answer questions on them when we arrive. Next slide, please. So we're down to questions. Thank you very much to Lisa and Tim, who have been collating the questions and getting them ready to share. So over to you, Tim.
Thanks ever so much, Janet. The first question actually is one that I'm going to take, which is it was about Fournier's gangrene actually, and also about the teratogenic drugs. And the question was, how can practices code so that patients don't actually turn up in these searches or the numbers go down when they're appropriately managed? And the aim of these searches, as Janet has explained, is to actually identify the cohort of patients, and then the GP specialist advisor on an inspection would critically look at the clinical record to make sure that the risk of pregnancy had been appropriately managed and documented within the record. So there's not an expectation that that number will potentially change. There was a question also about needing to register, and this is one for Roa, I think. So why is there a need to register with Ardens as the searches are now publicly available?
Thanks. So I hope everyone can hear me. Hi, nice to meet you all. My name's Rob from Ardens. So the reason this is only for EMIS Web practices that you need to register, it's not for System 1. And the reason it's for EMIS Web is due to how the search, how the searches work, and they need to be downloaded by each individual practice. Now, if we need to do an update or an urgent update of sorts, we will therefore know which practices have got which version, and will therefore be able to notify you and let you know there's a new version that needs to be downloaded and installed. So that's the only reason for it. As I said, it's only for EMIS Web, not for System 1 or else.
Thanks, Rob. There's also a question about Eclipse. And is there a need to duplicate the work of the practice by running both? And I think Janet was quite clear that that these searches are not intended to be an alternative to a practice's own internal clinical governance. Eclipse does look at many of the areas covered in this, and other searches are available from medicines teams and providers like Ardens to actually help practices go for the gold standard of monitoring and to detect people who are going to be overdue. And some systems, I believe, actually proactively identify people in advance for opportunistic screening when they come in. So it's not an either or. Many practices use Eclipse and find it extremely helpful. And it does look at other really important areas that our searches don't. Janet, can you expand? There's one question about the quality of medical reviews, medication reviews being assessed. You touched on it in your call, but the question is there objective criteria used for this, or is it subjective depending on the SPA's approach?
So when the specialist advisor comes to do the inspection, we have a series of templates that the specialist advisor completes to support each of the different searches. So there is a template for the medication review search, which I haven't got up in front of me, but it covers very much the things that I was saying. You know, is there evidence that the patient was involved where appropriate with the medication review? Are the drugs aligned in quantities? Is monitoring up to date? Have blood pressures been done according to the need? So it very much is should be a consistent process, because each of the SPAs should fill in those templates to gather the same information on each inspection.
Thanks, Janet. And there was also a question about ICE and doubt, you know, if results are actually on ICE, and most practices, or many practices, are able to download from ICE and then populate the clinical record, but where of course they can't, and we are actually working with others behind the scene to try and make this a universal approach to support clinical governance for practices. The demonstration that a test has been done in the form of mentioned in a hospital letter or actually appearing on ICE will of course be taken into account by the SPA. And there's also a question being raised about creatinine clearance and wondering whether that's normally done in secondary care rather than primary care. And our approach at CQC is that ultimately the prescriber is responsible for the safe prescribing of a medicine such as a DOAC. And if that does require the calculation of creatinine clearance, we don't mind where it's done, but there is an expectation that it will be done in that it can be done in general practice. Just so you're aware, there has been some controversy about ideal weight versus actual body weight, and we've had meetings with NICE and the MHRA and the system providers, and we are working our way through this because there's a difference between the recommendations in the drug data sheets and that appears in the that appears in the BNF. A question for Merlin. There's an EMIS practice and they don't have the misdiagnosis searches in their download. Any help?
Yes, so I've already replied to that. I mean, the download folder is exported as a single folder, so I'm a little bit mystified by that. I've passed them the exact name of the subfolder to have a look at, but if it persists, then I've given them the support email address to contact, and we can look into that at an individual practice level if needed. Great, thank you. And I think that the misdiagnoses, so there've been questions about misdiagnoses, especially of diabetes, which we're aware where patients hover around the borderline. They're sort of in the diagnostic range with a hemoglobin A1C, say, of 48 or 49, and then that drops back a fortnight later to 47, and that it can be very, very difficult. That the patients that we're really concerned about are the ones who are clearly diabetic with significantly raised hemoglobin A1Cs, who might have been put at risk with a lack of coding, and those are the ones that we are really interested in working out why they haven't been coded and given access to supportive care. There's a question about how these searches tie in with QOF. Do you want to take that, Janet?
Okay, thanks very much. So these searches are nothing to do with QOF. The long-term condition searches were developed partly because in our CQC reports now we're not using QOF data because obviously QOF was suspended during the pandemic and the currently available data it is not robust enough to be used. So we are using the long-term condition searches to just have a look at how the management of patients with chronic conditions has been undertaken over the last year prior to the inspection taking place. They aren't aligned to QOF, they're completely separate from QOF. And we aren't currently using QOF data in our inspections because of the fact that it's been postponed and halted and just put onto the sustained payment mechanism. When QOF is re-established and the data is considered to be reliable by NHS England and our data and intelligence team tell us that we can use it, we will be going back to using that. But you have to remember that QOF is a payment mechanism primarily, rather than a clinical quality improvement tool, although it can be that as well. And so with exception reporting or now personalised care adjustments, we always have a little look to make sure that practices aren't excluding patients from monitoring when we do use QOF data. Sorry, exclude them inappropriately, shall I say.
Thanks, Shannon. And a question for Rob or Merlin, but probably Rob actually. And I think I know the answer to this, which is nearly. And it's, are all the searches exactly the same across the 3 clinical systems?
Yes, they are as close as they can be. With the, I think so. We've created our own business rules that have been approved by the CQC panel. And they're on made available. I posted the link on one of the chat messages earlier, and you can see the rules that they're built on and the code sets that are used. Now, some of these codes are not available on System 1 or not available on EMIS Web and vice versa, but they should be as exact as possible. I think the main thing is, though, if you think there's any issues with any of these searches, then please always do let us know, because this is when we can look at it, revise it, and make any amendments if needed.
Yeah,
and just to add to that, the way that they've been written in some senses reflects our knowledge of system use as well. So there are certain elements which you can't mirror exactly on the 2 systems. So the default way of doing them in the systems varies, but we've discussed that with Tim and Janet as we've gone through in order to iron out those inconsistencies as far as possible.
Thanks very much. And there have been some questions raised around the CKD search, so I don't think there's an answer for it yet, but we will go back and double check the coding's all right for those, because more than one person's raised concerns that there might be issues with it. And just to finish off, there's one question, which is, would I be correct in saying that we now need to change our in-house procedures to assure that we code in accordance with these searches? And not necessarily is the answer. These are not meant to be a replacement. As we've said, probably the most important message for the whole webinar is that these are not a replacement for a practice's own internal governance mechanisms. And if those are going right, then when inspectors, when the GP specialist advisors look in the clinical records related to these searches, if the governance approach within the practice is effective at keeping patients safe, then there should not be a problem with these searches. Can I hand back to David?
That's
please?
great, Tim.
Can I hand back to you, David?
Yes, certainly. Well, thank you very much for answering those questions there. So we've come to the end of the webinar session now. If anyone's got any further questions, you can find a load of advice on the Ardens website, and you can also contact the email address that is on the bottom of that slide as well. And I will be sending out the slides and the recording of this session to everyone afterwards, so you'll be able to have a good look through the slides. You'll be able to watch those videos again, and there's also a lot of very useful links in there. So I'd just like to say thank you very much to Dr. Janet Hall and Dr. Tim Ballard, as well as Dr. Merlin Dunlop and Dr. Robert Grayville from Ardens, and also to my colleague Lisa Lloyd. And thank you everyone very much for joining us today. Take care and have a wonderful afternoon. Thank you.